we're here with Brand Finance and we're very lucky to have Hugh Montgomery OBE, who's Professor of Intensive Care Medicine at UCL.
Good. Thank you for having me.
Welcome, Hugh. We've just had a really interesting discussion around the launch of a new report from Brand Finance into reputation and brand strength for academic medical centres. You know, the conversation was wide-ranging and rich, and I wonder if you could just tell us what are the three things that struck you about that conversation?
Well, it's a really good point, because actually until I was invited here, I hadn't really thought day to day about reputation at all and why it matters in academic medical centres. A lot of what was focused on was that you've got to get the fundamental right. There's no point building a brand with weak foundations. So if patient experience and care is good, frictionless was a word that was used more than once, so the pathway is easy, and that people are perceived to bother, that the patient experience does well. Staff, if they're part of that process, then feel that they're delivering a high quality of care and want to recommend that centre to other places. Research seems to underpin all of it. If you've got good research, outcomes clinically are better, even if you're not in trials, for lots of reasons we could talk about in a minute if you wish. Therefore, patient care is better, which means that staff feel more rewarded, and education is attracted because students want to study in a place like Oxford because it's got great reputation for research. So those are big things. The fundamentals of good quality patient care is the bedrock, and then on top of that the research, which then drives all of the other factors together.
Reputation, what is it and does it matter?
Yeah.
What do you think?
It's interesting because I hadn't thought about what reputation was. I think to my mind there are probably three elements to it. The first is there's got to be a quality metric to it. So a reputation, good or bad, you know, someone a psychopath or a kind person, is the company doing well or going to go bust? What's its reputation for looking at our staff, or whatever it might be, some quality metric. But that intrinsic quality is not a reputation. It's only a reputation when it's communicated. So you might be a world-class tennis table player, for instance, I don't know, but you don't have a reputation for that if no one's seen you play or no one's communicated it. The third bit I think that underpins a lot of reputation is some other bedrock assessment, I think, of ethics or quality underneath. Is this person an honest, genuine person? Do I believe the brand value? Are they trustworthy, I think, is the other bit. And yes, it matters. It matters enormously, of course, to all of us in choice of services. In the healthcare, it means whether we want to go to that hospital or whether we run a far mile from going. But it also matters for recruitment and retention of staff as well, and for collaboration with industry, for innovation and care. If your reputation is you can't deliver, or you're lazy or stupid and you can't get your patient, whatever, you won't get. So reputation is absolutely essential on all those spheres, I think.
Well, so one of the things that struck me most about the report really was that up there in, I think, second place is one of the NHS AMCs.
Yeah.
And, you know, I think if you read the popular press today in the UK, you wouldn't necessarily imagine that any NHS institution would have such a strong brand. And maybe there's a case to be made that the NHS is winning in terms of its outcomes, but losing in terms of its ownership of a narrative. What's your view of that, and what needs to happen to close that gap?
I couldn't have put it better, actually. I think that's absolutely right, because a patient, let's imagine there's a hospital, I happen to work in one that has absolutely fantastic outcomes on a lot of things, but the patients don't see that metric, and there's no real way of marketing that metric to a relatively poor community in North London. What they will hear is when someone turned up to the emergency department and didn't get seen in time, or when something went wrong, because negatives always carry more than positives. And that narrative is also dangerous to the NHS's existence. We were talking in the meeting just now, the fact that 18% of GDP in America is spent on healthcare. In Britain it's 11%. But our outcomes across pretty much everything are as good, if not better, and efficacy and efficiency are also better. But the narrative you'd hear in Britain is the system's falling over, care is rubbish. And I'm not going to be an apologist for NHS care. There are lots of bits where it could be dramatically improved, but it's not as rubbish as the general perception would think that it is. And it's certainly very, very good value for money. So we do need something better on the comms, in my view, for that, because otherwise the narrative would always be your mate who got treated badly or where it didn't go right. And press, of course, always report the bad stuff, right? They'll report the litigation, or they'll report the sexual harassment or whatever else it might be. And bad reputation clings much more readily than good reputation.
I wondered if partly the challenge is sort of values in the NHS, and a sense that we shouldn't need to want to communicate this stuff, which touches on something else, I think, around values in the NHS of public-private partnerships and the opportunities those create, but our reticence really to move forward with them. I think you spoke a bit about that in your talk. I wondered if you could say just a couple of words on that.
Yeah, so I mean, I am a socialist for the NHS with a capital S. I believe that I got where I am, yes, by hard work, but by luck of my genes and by having a stable couple of parents and a good education. And I think it's quite right that I get taxed to support other people. And I like the idea that we, the British people, care for each other through that funding system. I therefore don't much like the idea of turning the NHS into for-profit, because I think that sometimes isn't more efficient, as we've seen in America. It's not more efficient, it costs more, but also it erodes trust, because if you come to see me as a doctor now, you can be confident, I mean, you can be certain that the decision I make is in your interest. It's not because I'm making more money, or I'm scared that you're going to sue me, or any other driver. You can trust the fact that I make the decision because it's what's best for you. Now, that does not mean we should not be working with commercial partners, because there is a sentiment that the NHS is the people's system and that anything private shouldn't go near it. And most people don't know the NHS doesn't do its laundry, it doesn't do its cleaning, it doesn't maintain most of its buildings. The IT and software isn't made by some NHS company called NHS Software. It's all commercial. And we have to overcome this issue to say it is okay to work with commercial partners. And you could take one example, for instance, NHS data are the richest data set in the world, bar none, on healthcare. I would be very happy with caveats about security and about privacy for those data to be shared with a commercial partner if it improved product and care that improved me. Now, that could bring a lot of revenue to the NHS. It could lower our costs in taxes, improve our care, and those products could be commercialised in other markets to earn profit for those for-profit companies. But this blanket, we will not work with you, I think is an error of public perception. I understand where it's come from, and I hope I've made clear that I'm on the side of the public on this one, but I think we should have more of these partnerships. And if you look, for instance, at the relationship between Oxford and Andy Pollard's team creating the vaccine, and with AstraZeneca for COVID, yeah, the vaccine had some side effects for some people, but it was a game changer. Britain led the world because we had those sorts of abilities to work with a commercial company. And there are huge advantages to doing that in other domains as well.
You know, one of the things that came through quite strongly, I think, in the debate was the idea that research and academia really underpins this space. And you spoke, you know, quite passionately about that idea. If you could elaborate for us. Yeah.
So firstly, academia in Britain, for sure, is a really hard track. It extends your training, stops you getting to a point when you earn a reasonable salary. It's really hard work, gives you very poor job security. There isn't a track. You know, you do all the research, and essentially, very often you have to raise your own grant money to pay your own salary. So it attracts the most tenacious, driven, often very bright, motivated and committed people. And those are the people you want to work in your centre. The second thing, they're at the cutting edge. They know what's going on. They can phone you. You're my mate who works in Charité in Berlin. We can trade information. It means that stuff happens quickly and in a frictionless way to promote the best of care. In terms of research, we know that if you are looked after in a research active hospital, your outcome is better. And that might be because the structures are in place that provide better care, but it's also because you've attracted the best of staff to deliver it. So if you look at National Institute for Health Research funding, government funding to hospitals for research purposes, the ones that are most research active have lowest outcomes. For colon cancer, for instance, a 1.5% lower risk of dying after an operation for the most active versus the least. And that might not sound much unless you're the 1.5%. Then it matters because it's binary, you're dead then. And there's a 3.8% difference in 5-year mortality. And this occurs even outside trials, as I say, it's a function of the activity being there. It attracts students. Students will come to UCL, where I work, or Oxford, and when you ask them at UCL, why did you come here? Oh, it's because it's academically fantastic. It's known to be this great centre, and that's the same. They're not coming for patient contact, they're coming because of the academic reputation. So for all of those things, you attract and retain and recruit the best staff. Patients want to be seen by you, their outcomes are better. And of course, it can make money for UK PLC or any other country come to that. If we get it right with the commercial partnerships, it helps support those health systems too. So I'm a massive advocate for it. I think there's a real danger right now that it will wither on the vine. The UK is bankrupt like many other countries. We're well over 3 trillion in debt. There are cuts going on everywhere because there have to be, I guess. We've got to balance the book somehow. But if we prune the vine for academia, you won't ever regrow it. If you chop it off at the roots, you won't be able to plant it and nurture it again.
Thank you.
You're welcome, thank you.